All right. Well, thank you very much, everyone. So nice to meet you. And I think this is my second or third time maybe coming to present. And so my name is Dr. Ergun. And so I also wanted to share, I know that I haven't also shared with you all too, but I was an associate professor at the School of Professional Psychology. I'm still a clinical faculty at Wright State University. However, this summer I have moved back to Turkey. So that's where I am presenting from. And but I'm still involved in my work with FASD through my grant and so forth, and still engaged in this line of work. So just wanted to share that as well. That's why it's kind of getting dark here, because we're 7 hours ahead. All right. So today I'd like to talk about fetal alcohol spectrum disorders, which is an area of expertise, and it's an area that I worked over probably 15 to 20 years in this specific area in terms of diagnosis, intervention, screening, and advocacy. All right, we can move to the next slide. I wonder if I can move, or probably you can move the slides, right? Okay. All right, just wanted to, I know with the first day of fall, and I am a fall lover. I love the fall. So I just wanted to share some nice pictures of the trees kind of like turning, which we will hopefully expect within the next month or so, but I love them all. All right, so today I wanted to be able to kind of like have you all and some of you might have had more knowledge on FASD, but understand the impact of alcohol on the unborn baby, understand some of the symptoms of FASD, some of the red flags in the young children, and then going on to adolescence, and then just gain the basic knowledge on the differential diagnosis between FASD and the other neurodevelopmental disorders. So when we say FASD, what I'd like to kind of like make very specific is that FASD is not a diagnosis. It is just an umbrella term that contains 4 different diagnoses underneath that, which I will talk about in the upcoming slides. What I'd like to share is that FASD is the most common leading cause of intellectual disability. And one thing I wanted to share is that we say it's preventable in the sense that if a woman knows that they're pregnant, if a woman is able to quit drinking, and then if they know about the impact of alcohol, of course, they would, abstain from drinking, and then FASD will not happen. So when we say preventable, as much as it can be, but it is the #1 cause of intellectual disability that is not genetic or due to other, reasons that are, prenatally. It's only caused by a mother during drinking alcohol during pregnancy. So if we do not have prenatal alcohol exposure, then we do not have FASD. And because alcohol is a teratogen, and it's a very harmful substance that passes through the placenta to the unborn baby, and then I'll talk about some of the impact that it has on the brain. You can go on to the next slide. So overall, in terms of the prevalence of FASD, I know I put a lot of information in this slide, but what I would like to say based on the latest prevalence studies is that it is around 2 to 5%. And that being said, what we can say safely is that it is more prevalent than autism. However, if we ask, some of the professionals, some of the, the parents, the lay people, they probably have not heard about fetal alcohol spectrum disorders. And so right now we are really working hard on making it known and then increase the awareness so that people are aware of the impact of alcohol on the unborn baby, and that there is actually a neurodevelopmental disorder called FASD. So I just wanted to bring that out to everyone's attention, is that it is quite prevalent, both in US as well as in the rest of the world, in the Western European countries as well. So how does FASD come around? So first of all, we need to have prenatal alcohol exposure. However, one thing that I'd like to attract your attention is that not all children exposed to alcohol consumption during pregnancy will be impacted at the same level. And the reason for this is that not one pregnant mother is the same as the other in terms of their ability to metabolize alcohol, their health status, their psychological status in terms of their stress level, their previous trauma experiences, any of the risk factors such as having domestic violence, the conditions that they live at home, and then of course, when they drank during pregnancy. Some women would drink during the first trimester before they even know that they're pregnant. So that leads to having the facial features of FASD. If a woman drinks more heavily during the third trimester of the pregnancy, that is when we have heavily the brain development of the baby, the unborn baby. That's when the impact on the structure of the brain happens the most, when there is drinking during the third trimester. Therefore, when we put all of this together, we can never say, oh, if you drink now, it's safer than the other. And all of the research studies indicate that there is actually no safe amount of alcohol during pregnancy. Therefore, all women and then women at the childbearing, age should abstain from drinking if they are wanting to get pregnant. So as I mentioned at the FASD, I said it's the umbrella term. I just wanted to also put a visual to that. But I think that's really important when if you're doing a diagnosis, if you're working with a kiddo who has a diagnosis of under one of these, this is a really nice visual to share with the parents as to FASD is an umbrella term. And then we have those 4 that I'm going to talk about diagnosis under this umbrella. So when we look at the one picture on the right, we see FASD and we'll see this iceberg. But what we see at the top of the iceberg is the physical defects, which is the facial features that for some of the kids with FASD that we can see, which we call fetal alcohol syndrome. That is the most severe form of FASD. But we can see the facial features, then we can say, oh, this child has FAS. However, a lot of the children under the FASD umbrella, they do not have the facial features, which means the mother did not drink necessarily during the first trimester. So we skip that part, but they still have a diagnosis under FASD. So that's why sometimes it's called the invisible disability. We do not see the facial features. They speak fine. Sometimes their IQ is fine. We don't see it, and we don't think that there is anything going on with this child. But then we see many other difficulties. So that's why a lot of the times these children are misdiagnosed with other disorders, which I'll be talking about. So under the FASD umbrella, so what are the 4 diagnoses that I mentioned? So first of all, we have fetal alcohol syndrome. So fetal alcohol syndrome is the full-blown and the most severe form of FASD. Under this one, to diagnose FAS, then a child needs to have a growth deficiency. So what that means is that the head circumference, the height and the weight should be below 10th percentile, which can be measured by a developmental pediatrician or a geneticist. So if you have any concerns, then referring to a geneticist as well as a developmental pediatrician would be helpful to determine that. Then what we look at the facial anomalies, which I'll show in the next slide. But there are a certain set of facial features that are characteristics of FASD. And then if a child has that one too, then it is more the fetal alcohol syndrome. Then we need to have neurodevelopmental deficits, which are some of the things that I will talk about regarding difficulties with memory, learning issues, self-regulation issues, and so forth. And of course, for all the diagnoses, we need to have both evidence and documentation of prenatal alcohol exposure. If we do not have that, we cannot provide the diagnosis. Therefore, for all of us who do intakes, like us social workers, therapists, psychologists, doctors, we need to have that evidence and documentation that there was prenatal alcohol exposure. Otherwise, it can be any other neurodevelopmental disability that is pretty similar. The partial FAS is that we have all of that, but we do not have the growth deficiencies. Then it means it's partial. And then the RAND, which is what most of the kiddos under the FASD umbrella qualify for, is the alcohol-related neurodevelopmental defects or disability, where they do not have the growth deficiency. They do not have the facial features, but they have all the neurobehavioral or neurodevelopmental impairments. And of course, there is prenatal alcohol exposure. So that's kind of like the most common type under the FASD. So on my right, as you can see, these are two brains of two babies that have passed away. The one on my right, the smaller one, the lighter one, is the brain of a baby with FASD, as you can see, and then the one on the left is a baby who has passed away from SIDS. So as you can see, the one on the right is quite small, and then they already had that microcephaly where, due to the impact of alcohol, the brain has shrunk. And as you can see, there are less folds and edges and ridges. So that means that there has been some structural changes in the brain where there are actually less of the neurons or the brain cells, which of course leads to a lot of functional deficits. And then the one on the left is a typically, a developed brain that has been formed, but of course, unfortunately passed away. So that's kind of like also a striking slide just to show the impact of alcohol on the unborn baby's brain. So what are some of the brain areas that are impacted? First of all, alcohol is a teratogen, as I mentioned, and it impacts the midline of the brain. So the midline of the brain impacts kind of like the development of the face as well. And that's why the babies later develop the facial features. So some of the structures that alcohol impacts in the brain is the frontal lobe, which is kind of like the area that impacts our planning, organizational ability, what we call executive functioning skills. And then the next one is the corpus callosum, which is the mid part of the brain that helps the two brains, the right and the left, to communicate with one another. And that's why kids with FASD have a lot of difficulties with passing information from one side of the brain to the other, which means they have a hard time processing information. They are slow processors, and then they have a hard time just learning and processing information, because what happens is that due to the alcohol impact, the corpus callosum is either thinned out, sometimes they are born without a corpus callosum, and sometimes some part of the corpus callosum does not develop. So there are structural difficulties there. Hippocampus is also impacted. Hippocampus is the hub for memory. Therefore, kids with FASD have a lot of memory issues. And we do not see that in other neurodevelopmental disabilities. So kids have normal, intact, memory, not with our kids with FASD. They learn, then they forget. They cannot recall certain things. So it's kind of like, having a TBI in the later years and not being able to, remember certain things. So if you have a kiddo who is in preschool and is struggling with learning, they learn, but that they struggle with remembering, retaining it, then that should be a red flag for us. Hypothalamus is impacted. Hypothalamus is a part of the brain where it helps us to regulate our daily cycle, wake cycle. We wake up, we do our day. That's due to hypothalamus. So kids with FASD are very dysregulated. They wake up in the morning, then there is this whole fight at home because they just don't want to go to school. They feel like they have some sensory issues. They are dysregulated, they have tantrums just for, the parents say like just for nothing that they're dysregulated. It's due to the damage in the hypothalamus area. Another area that's impacted is the cerebellum. Cerebellum is the lower part of the brain, and that's an area that kind of helps us with our balance and our coordination. So kids with FASD are not very well coordinated, and then they have difficulties with fine motor and gross motor issues. So you could see a lot of these kids being referred to OT and PT. Amygdala is an area in the brain that controls our emotional regulation, and kids with FASD are also very much emotionally dysregulated. They have a hard time with regulating and controlling and managing their emotions. So a lot of explosions do happen as a result of that. Basal ganglia, finally, is the area that also kind of like helps us with coordinated movements. And therefore, kids with FASD have a lot of difficulties with managing, again, their coordinated movements, and they're pretty clumsy as well. So this is kind of like the typical facial features that we would see. First of all, we would see a smaller head. As we have seen, the brain size shrinks. Therefore, there is microcephaly, so which causes them to have a smaller head. Then we have these small eye openings, the epicanthal folds and the small eye openings, and then the low nasal bridge, it's pretty low. So because alcohol impacts the midline of the brain, then we have this flattened face to the side. So then they don't have the cheekbones as much. The face is pretty flat. And then they have a very smooth philtrum. Philtrum is the area between the nose and the lips. If you all do this, there is some kind of like going up like that for everyone. And the kids with FAS, which they have the facial features, is pretty much flattened out. And then they have the underdeveloped jaw, and then they have the thin, very thin upper lip. So these are the characteristics. These facial measurements can only be done by a developmental pediatrician or a geneticist. Therefore, we need to refer out if we have any suspicion. So I just wanted to put it out there just to showcase that these facial features are across race and ethnicity. As you can see, these beautiful children, they all have the same facial features that I just talked about, but they are all from different races and ethnicities and show the same facial patterns. And they all have FAS, the full-blown fetal alcohol syndrome. So now next, I wanted to talk about what it looks like in different phases of life. So early in infancy kind of looks like any other neurodevelopmental disorder. They don't respond to parents. They have feeding issues. They have sleeping issues. They don't start to coo or babble right on time. Next, in toddlerhood, so what do we see? So during toddlerhood and preschool, they kind of like start school a little bit. They learn the concepts. They learn their numbers, shapes, and colors. The next day, they don't remember anything. That's because of the memory difficulties. And we think that it's just a learning issue. No, they can learn, but they do forget very easily. So they need a lot of repetition. We see a lot of hyperactivity very early on, as early as 2, which is different than our traditional ADHD. Very aggressive. They can be very destructive. And then we start seeing a lot of difficulties with receptive and expressive language problems. So the parents come and say, for a 3-year-old, I've tried everything from timeout to, all the positive reinforcement to negative reinforcement, just punishment, everything. Nothing is working with my child. What do I do? So if you see these very severe cases, then you might also have maybe a red flag for FASD. Next, in the childhood years, then we start seeing short attention span. Around 50 to 60% of these children also have ADHD because it impacts the same area, which is the frontal lobe, right? So they have difficulty with coordination, as I mentioned. They have now hard time learning in school. So a lot of them then get diagnosed with specific learning disabilities and ADHD. They have hard time regulating themselves. Now we see some delayed adaptive skills and also difficulty learning to tell time and use money. So that could be also your red flag, because kids with ADHD, autism, they don't have any problems with learning how to tell time and use money. So those could be like very specific to FASD and the memory deficits. In adolescent times, all of these just kind of like start piling up on one another, okay? And then now what we see is the social issues, because they can be very gullible or naive, and they can be very easily taken advantage of. So for example, the client where, a group of teenagers, they're just walking around, and then their friends could tell this teen with FASD, oh, let's just take this car and go for a ride. Well, all of the other teenagers know that that is stealing, that you can't do that. And then they let the teen with FASD do that. And then because they wouldn't question for a second that, oh, we were just going to go for a ride. So when they get arrested, then this teen will say like, well, we just wanted to go for a ride. What's wrong with that? Because they really have a hard time understanding the cause and effect. If I do this, this is what's going to happen. And for them, it's just for going for a ride, and they don't do it necessarily for a malicious reason and so forth. So now they have more problems with, peer pressure, as well as being taken advantage of. And then they could have some secondary issues, such as getting into trouble with the law. In adolescence, some of the secondary issues become, now they start to have some mood disorders on top of it. Now they had all the behavioral issues, they had the ADHD, they start to have learning issues. Now on top of that, they could have depression, anxiety, trouble with the law. Now they don't know some of the consequences of their behavior, so they could have sexual promiscuity as well. And now because of the impulsivity, they could also engage in drug and alcohol use. And in adulthood, of course, finding employment is a big issue because they have a hard time with managing money. They have a hard time with getting the deadlines, so that's working in a job is kind of like really hard. They could have some hypersexuality issues, and then lack of respect for social rules and authority, not for the sake of just being non-compliant, but they have a harder time understanding some of those despite having an average IQ, for example. That's the part where people struggle understanding them. They might say like, well, you're not a person who has intellectual disability. Why don't you understand this? So they get this a lot, but they can't because it is more a brain-based disorder. So these are some of the things in adulthood. So next, and the last part, I wanted to talk about comorbidity. FASD is comorbid with many other neurodevelopmental disorders. And now you can guess why, because I shared with you all the brain structures that are impacted. Well, guess what? Autism, ADHD, learning disabilities, they are the same parts that get impacted, but more genetic reasons. This one is only due to alcohol, but it's the shared same brain structures that are impacted. Therefore, they share a lot of symptoms with other neurodevelopmental disorders, such as ADHD. Almost half of them have ADHD. Intellectual disability, 43%. Learning disabilities, 30%. Language disorders, 67%. And a lot of the behavioral disorders. So I wanted to kind of like showcase a couple of slides about comorbidities and how we can differentiate. And maybe you might say like, well, I'm not doing these assessments like you, Dr. Ergun, but that doesn't matter. And maybe some of you do as well, but you are all referring, you are consulting with one another. You're saying like, oh, should we refer them for a psychological evaluation, or should we change their treatment plan based on their diagnosis that we see in the report? So that's why I thought maybe that would be very relevant. As far as the shared aspects, both ADHD and FASD, they have executive functioning deficits because it's same in the frontal lobe. One is due to alcohol, the other one is genetic, right? So they still have attentional issues. But what are some of the things that's differentiating one another? One thing is that kids with ADHD only, they can process information very nicely. They are sharp, and then they can just go like that. But kids with FASD, they are slow due to the issues in the brain to process information. And then kids with ADHD, they do not have social related issues. Well, they're probably just a little impulsive. They might get into trouble because they touch other people. They're just like kind of like very hyperactive. But all in all, they make friends. They are not easily taken advantage of and so forth. So that's kind of like another differentiation. And then as far as the motor difficulties and so forth, kids with ADHD have mild gross and fine motor issues, but kids with FASD have a lot of coordination issues, fine motor and gross motor issues. So those could be some of the things that differentiate the two. And another aspect is that kids with ADHD benefit from stimulant medication, okay? Whereas kids with FASD who also have comorbid ADHD don't really benefit from typical ADHD medications. So that's another very important thing you might come across maybe when you do your record review, okay? A lot of people ask me about, what about autism? Because they share a lot of some of the social issues and so forth. Well, the shared aspects are that they both can sometimes engage in inappropriate behaviors. They have problems with peers, and then they have a hard time getting the social cues. But what is different is that kids with FASD, they are very social. They want to make friends. They put themselves out there. They don't shy away from interaction. They actually want to make friends. They're out there, but they just don't know how. And then they get themselves into trouble because they are too gullible. They could be naive. They want to please others. They're going to be the ones who want to please others all the time. And therefore they show poor judgment. Okay. However, our autistic children, not all of them, but again, most of them, they're okay on their own. They don't want to initiate as much. They're more in their own world. So those are some of the differences, between FASD and then ASD and how we can differentiate. Also, a lot of the kids with FASD get misdiagnosed with ODD or conduct disorder, okay? So the shared aspects is that they both show aggression, noncompliance, and disobedience, okay? However, kids with ODD, The triggers for their outbursts is that when they don't get their way, when they want to get something, that's when they kind of like have an outburst. But the outbursts for FASD is when they have sensory issues, when they are dysregulated, or when they just don't understand cause and effect. That's more the trigger. So we always need to look at the functional cause, like why are they having these outbursts? If we ask this question to ourselves, we can pretty much almost, discover the diagnosis there as well, okay? And then kids with FASD are less mature than their age. They act much younger than their age. But our traditional kids with ODD, who have just ODD, they act their age. They just don't want to comply, okay? So that's kind of like that distinction. And then FASD and the learning disabilities is that they both have learning disabilities. They both have low achievement. However, our kids with learning disabilities, what we kind of like see is that for kids with FASD, they are slow in processing, which I repeated many, many times. And then our kids with FASD, they have more writing issues and math related issues. Very heavy math learning disabilities is seen in specifically in FASD compared to our more traditional kids with learning disabilities. So why is early diagnosis important? And then why do we want to know about all of this? Because early diagnosis is the key. If we can diagnose at or before age 6, and if we can place these children in a loving, stable home, because believe me or not, 70% of these kids are not living with their biological parents, because the biological parents might they usually continue to have alcohol or drug related issues. They're separated from their birth parents. And as a result of that, they're always in the system. So for those of you who are working with kids in the system, you probably encounter the FASD diagnosis a lot. But if they are placed in a loving and a stable home, and they don't jump from one home to another, or from like one facility to another, then we can have a better prognosis. So therefore, early and accurate diagnosis is the key. And then another piece is that if we can tell the school why they're struggling, if we can tell their foster parents, adoptive parents, why they're struggling, they could stop with just giving them the traditional behavioral therapy or some talk therapy, and then we can provide them more catered treatments as well. The missed and misdiagnosis rate is extremely high in FASD. I'll give you one number, hope that sticks, 80%. That is striking, right? 80% of these kids are wrongly diagnosed with all the diagnoses that I mentioned, or the diagnosis of FASD is totally missed and no one has caught that there has been prenatal alcohol exposure. So that's pretty disappointing at this point in terms of these statistics. And if we do not diagnose on time, then what we end up is the secondary disabilities. So we have all the FASD symptoms. We don't provide the right treatment. We don't provide the right diagnosis. Then we end up with all the secondary disabilities such as depression, anxiety. Then we see suicidal behaviors, disrupted school experiences, drop out of school, trouble with the law, inappropriate sexual behavior, arresting, and then drug and alcohol use problems. And then they all end up and pile up together. So when should we refer? If we have evidence that the mother consumed alcohol during pregnancy, that is extremely important. Even if we suspect, then we can start to look out for that evidence or that documentation. Maybe it's somewhere on the CSB records of the mom or the child, somewhere written in there in one of the medical records, okay? If the child has the facial features, or we suspect that, we can refer to a developmental pediatrician or the geneticist. Or if the child displays any of the behavioral or neurocognitive characteristics of FASD that I just talked about today in terms of the red flags, then that would be a great time to refer. And early screening and the interventions is the key. 86% of the children with FASD have never been properly diagnosed and they have been misdiagnosed. And more than 66% of children with FASD do not receive early intervention. Even if you think that, I don't have a place to refer this child, but I think I have a kind of this feeling that might happen, just please go ahead and refer them for early intervention services. Anything would help. Speech, PT, OT, working with a psychologist early on. Maybe they'll catch on at someone will catch them on at some point and give that diagnosis. but early intervention services would be so helpful in those 0 to 6 age, okay? Because unfortunately, and I'm in this business, but average age of the diagnosis is 9.5 years old. It's very, very late compared to, for example, autism, which is 5 to 6 years old. Okay, so if we can all screen and then refer for treatments, that will be wonderful. Well, if you have any further questions, please, thanks for listening again. And then please send my questions to my email. I'll be very happy to, contact and get in touch with you as well.